Hello and welcome to the Deep Dive. We're here to take these, well, frankly, intimidating stacks of research and distill them down into the high-impact knowledge you really need. Today's challenge is a big one: navigating primary immunodeficiencies and those complex immune responses. If you've seen all those acronyms CVI, XLA, LAD, CGD, the symptoms can look awfully similar. So our mission today: cut through that confusion. We want to give you clear differential markers. How do you tell B-cell failure from T-cell failure, or phagocyte defects from those really scary, acute hypersensitivity reactions? It's all about the underlying mechanism. That's what guides everything.
Absolutely. Precision is just paramount here. Like you said, knowing if a patient has, say, normal B-cell counts, but they just don't work right, versus having basically no B-cells at all, that fundamentally changes the entire prognosis, treatment, everything. We're hunting for those diagnostic anchors, the key facts that help you separate these conditions quickly. Okay, let's unpack this, starting with the basics. Deficiencies of humoral immunity. This is where the antibody production, the factory, is failing. So when we talk about things like common variable immunodeficiency, CVID, or X-linked agammaglobulinemia, we're talking about a failure to make enough immunoglobulins IgG, IgA, IgM.
Yeah, and for you listening, trying to build that mental framework, the real trick in this humoral group seems to be sorting them by two main things. When does it show up, and how many B cells are actually around? So let's start with CVD, common variable immunodeficiency. People often call this the later onset one, right?
That's generally true. Presentation is usually in adolescence or young adulthood. Think age 20 to 40 is a common window.
And what do they come in complaining about?
Typically, it's recurrent, pretty serious infections, sinopulmonary stuff, chronic sinusitis, lots of pneumonias, and also they often have trouble with GI bugs, like Giardia.
So what's actually going wrong in CVI?
The core issue is that their B cells can't properly differentiate into plasma cells, the antibody factories. They're functionally impaired.
So you get low IgG.
Low IgG, definitely. Plus, usually low IgA and/or IgM as well. And this is the really critical diagnostic point if you run flow cytometry. Yeah, your B and T cell counts are typically normal. The cells are physically there.
Okay, so the numbers look fine on the lab report, but they're just not doing their job. How do we actually prove that?
You challenge them. The absolute hallmark of CV is a poor or sometimes completely absent antibody response to vaccines.
Oh, wait.
If they can't mount a defense against something standard like tetanus or pneumococcal vaccine antigens, you know that process is broken.
And because it's a primary defect, this isn't something they grow out of.
No, unfortunately not. Management is lifelong. Regular IVA, immunoglobulin replacement therapy is the standard.
Okay, so that's CVID, later onset, normal B cell count, but poor vaccine response. Now, let's contrast that with X-linked agammaglobulinemia, XLA, also called Bruton's.
Exactly. Big contrast here. CVD is often adults, B cells present but faulty. XLA is a severe childhood disease.
So it starts much earlier.
Much earlier. The first few months, babies are usually fine because they have mom's IgG antibodies circulating.
Right, passive immunity.
But once that maternal IgG wanes, usually around 3 to 6 months old, the severe infections start kicking in. And this is all down to a specific gene mutation, the BTK gene.
And that BTK mutation, that's the key difference maker.
It's everything. It causes a profound block early in B-cell development. So, unlike CVE, where the cells are there but don't work well, in XLA you have markedly decreased or even completely absent circulating B cells. Your CD19 plus count is extremely low.
And that means?
It means very low levels of all the immunoglobulin classes, IgG, IgA, IgM, all of them.
Did you mention there's a physical exam clue that can point towards XLA?
Oh, absolutely. It's a great one. Because B cells are crucial for developing lymphoid tissues, these little boys with XLA often have tiny or even absent tonsils and adenoids. You might not feel lymph nodes either.
Wow, so you can sometimes see the lack of B cell development.
You can. It's a really strong clue. Now, clinically, both CVI and XLA patients get those recurrent sinopulmonary infections from encapsulated bacteria. But notice that Giardia lamblia keeps popping up in both.
Yeah, the GI connection.
It just hammers home how vital those antibodies are for protecting our gut lining, our mucosal surfaces.
Okay, let's tackle another one in this group. Hyper-IgM syndrome. The name kind of gives it away, but the immune profile is really distinctive, isn't it? Almost upside down.
It really is. This is usually X-linked, caused by a defect in the CD40 ligand on T cells.
And what does that CD40 ligand normally do?
It's essential for class switching. B cells naturally start by making IgM, but to switch to making IgG, IgA, or IgE, the more specialized antibodies, They need that interaction between CD40 on the B cell and CD40 ligand on the T cell.
So if that interaction fails,
The B cells get stuck. They can only produce IgM. They can't make the switch.
leading to high IgA.
Exactly. Very high IgM levels, but severely decreased IgG and IgA. That pattern is pretty much diagnostic. And like XLA, this also presents early in infancy with severe infections. Now, before we leave humoral immunity, there are two quick but really important scenarios to flag. First, one that often causes worry but usually resolves. Transient hypogammaglobulinemia of infancy, or THI.
Okay, what's the story there?
The baby's IgG level stays low past that typical 6-month mark, which looks concerning, kind of like the other conditions. But here's the difference. Their B cell count is normal. And crucially, their antibody response to vaccines is normal. They can make antibodies when challenged.
So it just takes them a bit longer to get their IgG production up to speed.
Precisely. It typically resolves all by itself by age 2 to 4. You just monitor them, watchful waiting.
That's reassuring. And the second high-yield one?
Selective IgA deficiency. This is actually the most common primary immunodeficiency. Most people are asymptomatic or maybe have slightly more mild respiratory or GI infections.
Okay, seems less severe. But there's a catch,
Yeah.
right? A really important one.
A potentially life-threatening catch. Some of these individuals develop Ig antibodies against IgA.
IgE against IgA. Okay, so what happens if they need blood?
If you give them standard blood products like plasma or platelets, which contain normal amounts of IgA, they can have a severe anaphylactic reaction during the transfusion.
Wow. Okay, that's critical. So they need special blood products.
They absolutely do. Washed red cells or plasma from IgA-deficient donors, knowing that risk is the key clinical takeaway for selective IgA deficiency.
All right, that covers the antibody factory side. Now let's switch gears. Let's talk about the cells that actually do the hand-to-hand combat. T cells and phagocytes. Defects in cellular immunity.
Yeah, this is a fascinating area. What's really neat is how these conditions often fall into two buckets. You have cells that just can't get to where the infection is,
Okay.
and then you have cells that arrive at the scene but then can't actually kill the pathogen they encounter.
Can't get there versus can't kill. Got it. Let's start with the ones that can't get there. Leukocyte adhesion deficiency, LAD.
Right. LAD is caused by defective CD18 integrins. Think of these integrins as molecular Velcro on the surface of neutrophils.
Velcro.
Yeah, they allow the neutrophils, which are flowing in the blood, to grab onto the blood vessel wall, stick, and then squeeze through into the infected tissue.
So if that Velcro, the CD18, is defective.
The neutrophils can't stick. They can't migrate out of the bloodstream and into the tissues where the infection is brewing.
Okay, and that leads to a really strange clinical picture, doesn't it? They get infections, but something is missing.
Exactly. They get recurrent skin and mucosal infections, often bacterial, but when you examine the infection site, there's no pus.
No pus. Even with a bacterial infection. Why is that so specific? Especially since their blood tests show really high white counts. Lots of neutrophils.
That's the paradox. Pus is basically just dead neutrophils piled up at the infection site. In LAD, the neutrophils are stuck in the blood. That's why the count is sky high there. But since they can't physically get out of the blood vessel and into the tissue...
There are no neutrophils at the site to die and form pus.
Precisely. So you get this triad, recurrent infections, super high white count in the blood, but no pus at the site. And there's another classic clue often seen in newborns.
Oh yeah, the umbilical cord.
Delayed separation of the umbilical cord. Normally it falls off within a couple of weeks. In LAD, it often stays attached for more than 3 weeks, sometimes much longer, because neutrophils are needed for that normal separation process too.
Okay, LAD. Can't get there, no pus, delayed cord separation. Now let's flip to the other side. The cells that get there but can't kill. Chronic granulomatous disease, CGD.
Right. In CGD, the phagocytes, neutrophils, macrophages, they arrive at the scene just fine. They can even engulf the bacteria or fungi.
Then
Then the killing mechanism inside fails. The problem is a defective NADPH oxidase enzyme system.
NADPH oxidase, what does that normally do?
It's responsible for the respiratory burst. It generates reactive oxygen species, things like superoxide, hydrogen peroxide, essentially the chemical weapons the phagocyte uses to destroy the microbe it just ate.
So it swallows the enemy, but its internal weapon system is jammed.
That's a great analogy. The bug survives inside the phagocyte,
Yeah.
protected from other immune mechanisms.
And that failure, that specific enzyme defect, leads to a very particular pattern of infections, doesn't it? They're susceptible to certain types of organisms.
Absolutely crucial point. Patients with CGD are uniquely vulnerable to catalase-positive organisms.
Catalase positive. Why that specific group? What does catalase do?
It's all about hydrogen peroxide.
Oh,
Even though the CGD phagocyte can't make its own peroxide effectively via the respiratory burst, it might still be able to use tiny amounts of peroxide produced by some bacteria or present in the environment to try and kill them.
okay.
But catalase-positive organisms like Staph aureus, Aspergillus, Nocardia, Serratia, Burkholderia, they produce the enzyme catalase. And catalase breaks down hydrogen peroxide.
Ah. So they destroy the very weapon the weakened phagocyte might have tried to use against them.
Exactly. They neutralize that backup mechanism, allowing them to thrive inside the phagocyte. That's why this list of bugs is so characteristic of CGD. They also tend to form granulomas, these collections of immune cells trying to wall off infections they can't clear, especially in the GI or urinary tracts.
And managing CGD requires hitting both potential threats, right? Bacteria and fungi.
Yes, prophylaxis is key, and it's a double whammy. Both trimethoprim, sulfamethoxazole, TMP-SMX for bacterial protection, and itraconazole for fungal protection, especially against Aspergillus.
And the diagnostic test.
The gold standard now is the dihydrohodamine test, or DHR, done by flow cytometry. It directly measures whether the patient's neutrophils can actually produce that oxidative burst when stimulated, much better than the older NBT test. Quickly touching on another condition with cellular defects, hyper-IgE syndrome, also known as Job syndrome. It involves impaired neutrophil chemotaxis, difficulty moving correctly, but the clinical picture is really different.
What stands out with Job syndrome?
3 things, usually. Severe eczema, starting early, very high levels of IgE in the blood, high eosinophil counts, and these really unique cold abscesses.
Cold abscesses. That sounds so strange. What makes them cold?
They're abscesses, often staphylococcal, but they lack the usual signs of inflammation. They're not particularly red or warm or tender.
Again, pointing to a problem with the normal inflammatory response, even though there's infection.
Exactly. The signals are getting scrambled. And finally, in this cellular group, we have to talk about the most severe form of primary immunodeficiency. Severe combined immunodeficiency, or SCID.
SCID. This isn't just one cell type failing, is it?
No, it's a catastrophic failure, primarily of T cell development. But because T cells are essential for helping B cells function properly, you end up with a profound defect in both cellular and humoral immunity. It's truly combined.
And the clinical presentation reflects that severity, right?
Tragically, yes. Infants present very early with severe recurrent infections, including opportunistic ones you shouldn't see in a healthy baby, like pneumocystis jirovecii pneumonia. They also have chronic diarrhea, failure to thrive.
And physically, like XLA?
Yes, it's similar to XLA. There's often a lack of lymphoid tissue, absent tonsils, no palpable lymph nodes. The immune system just hasn't developed.
And management has to be drastic.
Absolutely. First rule, avoid all live vaccines. Things like rotavirus, MMR, varicella, these could be fatal in a child with SCID. The only definitive cure is a hematopoietic stem cell transplant, ideally done very early in life.
Okay. Wow. So we've covered the chronic deficiencies, the B cells, the T cells, the phagocytes. But now let's shift gears, because sometimes the immune system doesn't just fail it. It overreacts violently and acutely. Here's where it gets really interesting, maybe even more immediately life-threatening. We're moving into hypersensitivity reactions.
Yeah.
How do we tell these apart when a patient presents in crisis?
Exactly. Timing is everything here. Let's start with the classic type I IgE-mediated reaction, anaphylaxis. This is severe, it's rapid, and it hits multiple systems: skin, airway, GI, cardiovascular.
And the absolute first step in management needs to be automatic, almost reflexive.
Non-negotiable. Burn this into your memory. Intramuscular epinephrine is the first-line treatment. Immediately.
Even if their blood pressure seems okay initially?
Yes. You do not wait for hypotension. You treat, based on the clinical picture, respiratory distress, oropharyngeal swelling, diffuse hives, signs of shock. Delaying epinephrine is directly linked to increased mortality. Hypotension is a late sign, not a prerequisite for diagnosis or treatment.
And we need to be aware of that delayed reaction too, right? The biphasic response.
Absolutely. Symptoms can seem to resolve, but then roar back anywhere from 1 to sometimes up to 72 hours later, though usually within 8-12 hours. If that happens, it requires repeat doses of epinephrine. That's why observation after initial treatment is so important. Okay, that's anaphylaxis. Now let's talk about swelling, specifically angioedema, because not all swelling is the same, and getting it wrong can be fatal. There's a key differentiating trio here.
Lay them out for us.
Okay, number 1, allergic angioedema. This is typically histamine-mediated, so the big clue is that it's usually associated with other signs of allergy, namely urticaria, hives, and pruritus, itching. If you see hives and swelling, think histamine.
Makes sense. What's number 2?
The big drug-induced culprit, ACE inhibitor-induced angioedema, this is not histamine, is bradykinin-mediated.
Ah, different pathway.
Totally different, and the key feature is swelling, often to the face, lips, tongue, larynx, without any hives or itching. It can happen days, weeks, months, even years after starting an ACE inhibitor.
And the treatment?
Stop the ACE inhibitor immediately. Antihistamines and steroids won't work well because it's bradykinin, not histamine. Airway management is critical if there's laryngeal involvement.
Okay, so no hives is the flag for ACE inhibitor angioedema. What's the third type?
Hereditary angioedema, or HAE. This is a genetic condition, usually autosomal dominant, caused by a deficiency or dysfunction of C1 inhibitor.
C1 inhibitor. What does it lead to?
It leads to uncontrolled activation of the complement and kallikrein-kinin systems, resulting in overproduction of bradykinin.
So, like the ACE inhibitor kind, it's bradykinin-mediated.
Exactly, which means, again, recurrent episodes of swelling, often extremities, face, airway, GI tract without hives or itching. It can be triggered by stress or minor trauma. The diagnostic clue is a persistently low C4 level, even between attacks.
And treatment is specific.
Very specific. Acute attacks are treated with C1 inhibitor concentrate or drugs that block bradykinin production or its receptor, like icatibant or calantide, not antihistamines.
Got it. Allergic has hives. ACE inhibitor and HAE do not have hives and are bradykinin-mediated, needing different approaches. Okay, one more reaction type to differentiate. Serum sickness. This isn't immediate, right?
Correct. Serum sickness is a classic type 3 hypersensitivity reaction. It's caused by immune complexes, antigen-antibody clumps depositing in tissues. Critically, it occurs 5 to 14 days after exposure to a foreign protein.
What kind of foreign protein usually?
Historically, it was anti-sera from animals. Nowadays, it's more often seen with certain drugs like some antibiotics, beta-lactam, sulfa drugs, or particularly monoclonal antibodies used in therapy.
And the symptoms. Is there a classic triad?
There is. Think. Fever plus an urticarial rash. Hives can be present here, unlike bradykinin angioedema, plus arthralgia or polyarthritis joint pain, sometimes lymphadenopathy too.
And how is it managed?
It's generally self-limited. The key is identifying and stopping the offending agent. Symptomatic treatment with antihistamines and NSAIDs, sometimes steroids if severe.
Okay, so what does this all mean? We've covered a huge amount of ground, from missing antibodies to cells that can't move, cells that can't kill, and these sudden dangerous overreactions.
We have. And if you zoom out, the path to diagnosis really hinges on nailing down that specific mechanism of failure, just like you said at the start.
Yeah.
It becomes much clearer if you keep that framework in mind.
Humoral defects, think timing and B-cell quantity. Is it CVID, later onset, normal B-cell numbers but poor vaccine response? Or is it XLA infancy onset, virtually no B-cells?
Right.
Number 2, phagocyte defects, think movement versus killing. Is it LAD neutrophils can't get out, so no pus, delayed cord separation? Or CGD neutrophils can't kill catalase-positive bugs like Aspergillus? And number 3, acute crises, think mediator. Is it anaphylaxis, IgE mediated, needs immediate epinephrine? Or is it angioedema where you must ask, are there hives? If no hives, think bradykinin, ACE inhibitor or HAE, and manage the airway, not just antihistamines.
It really is incredible how one tiny molecular defect, a faulty enzyme, a missing receptor, completely changes how the body defends itself or fails to. Specificity in diagnosis leads directly to effective, sometimes life-saving intervention.
It does. And this brings up a deeper question, something for you, the listener, to consider as we wrap up. We've seen these primary immunodeficiencies can show up across the lifespan. We treat the antibody deficiencies like CV with IVIG, which is great for preventing infections, but the underlying immune dysregulation that caused the deficiency in the first place, that often persists. So the provocative thought is this: what are the long-term trade-offs of managing these conditions? We replace the antibodies, controlling infections, but does that fully mitigate the increased risk of other complications we see down the line in some of these diseases, things like autoimmune conditions or even certain malignancies, which are known risks in CV or ataxia-telangiectasia, for example? The IV refixes one part of the problem, but is the immune system still fundamentally off balance, posing different threats over a lifetime?